Hi, this is Pat Ruggles, and I'm welcoming you to our Poverty Now series. And today we're going to be talking with Stacy McMorrow of the Urban Institute. She's a principal research associate in the Health Policy Center at Urban, and she studies issues relating to state and national healthcare reforms, and is really interested in data and poverty kinds of issues, just like most of the folks we talk to. So Stacy, we welcome you, and we're looking forward to hearing what you say. Oh, and Jamie, I see you have arrived. Good.
Yes, I have been allowed into the meeting, and I also want to extend my welcome. And when you're finished, I'll see if I have a few comments, and then we'll have a general conversation.
Sounds good.
Sounds great. Thank you. Great. So thanks so much. I'm really happy to be with you all virtually today. I am going to talk a little bit about something that I'm pretty passionate about, which is Medicaid and the Children's Health Insurance Program and their role in disrupting the relationship between poverty and poor health. So I have to admit that I was a little bit intimidated when I was first asked to discuss sort of broadly poverty and healthcare access and outcomes, since that's a pretty complex relationship and one that is pretty hard to disentangle. So let's see, make sure, oops, there we go. There we go. Okay, now we're moving. So we know, of course, that poor health is associated with low income in many different ways. So we know that poor health can limit people's ability to work and to earn income. And despite the fact that there are disability income and insurance policies that allegedly support people who are unable to work due to health conditions, those policies are complex. They often involve long waiting periods, and a lot of people who have conditions that limit their ability to work don't actually qualify for disability insurance or income. And then the other way that poor health can kind of affect people's income or their financial security more generally and put them at higher risk of being in poverty is the cost of medical care itself. So we can see kind of some statistics here. The average out-of-pocket spending in the US was about $400 for people who were in excellent health in 2016, and it was about $1,200 for those in poor health. And of course, there's wide distributions around those statistics where many people spend much, much more than that. We also can see evidence that about 15% of non-elderly adults reported living in a family where someone had problems paying their medical bills in 2018. And some really interesting work that was done by the Kaiser Family Foundation and the New York Times kind of ran through a lot of questions for people who did report having problems paying their medical bills. And many, many of those people also report trouble meeting other basic needs. So really, the struggles of medical bills can spill over into other areas. And of course, in the most extreme case, healthcare costs can lead to bankruptcy. And some studies have found that an estimated 26% of bankruptcies among low-income families are attributed to medical costs. So here we can just see some statistics that bear out this relationship, that people in poor health are less likely to be employed, they're more likely to be outside of the labor force, and they're more likely to be in poverty than folks who are in good health or excellent or very good health. So just kind of showing the general relationship between health status and some of these patterns. And then the other thing, though, is that this relationship works in the opposite direction as well. So poverty, of course, can affect people's health status in a number of different ways. It can limit affordability of healthy food. It limits the ability to afford safe and stable housing, and then housing can affect health. It limits educational opportunities, and education can then again affect health. And where I'm going to spend the bulk of our time talking today is poverty limits people's ability to afford health insurance and to afford medical care, and that can therefore affect their health. So what we can see here again is just the relationship between income and uninsurance. This is for non-elderly adults in 2018 from the National Health Interview Survey, showing that about 24% of non-elderly adults, less than 138% of poverty, were uninsured. That decreases a little bit as incomes go up to 250 and decreases a lot when you get to incomes above 250. And similarly, people who report having unmet needs for medical care due to cost are pretty similar for those everyone below 250% of the poverty level, and then decline quite a bit when you get above that level. So this is where Medicaid comes in, right? So basically what I've talked about so far is the relationship on the bottom. Poverty affects health, health affects poverty and ability to earn income. And Medicaid is kind of what has allowed us to really get a better understanding of this relationship and how to disrupt it, because it has state level policy and changes over time that have really given us the opportunity to study this relationship in a way that has been illuminating in a number of different ways. So I'm hoping that folks will forgive me if this is things that they already know, but I just wanted to do a very quick overview to make sure everyone's on the same page in terms of what is Medicaid. It was established in 1965 in conjunction with Medicare. It's an entitlement program that provides health coverage to low income and other vulnerable populations. It's jointly financed by the states and the federal government. And the really important piece about Medicaid, which has led us to be able to do so much creative work to understand this relationship between poverty and health, is that states establish their own programs within broad federal guidelines. And so there's a lot of variation across states in how they implement their Medicaid programs, and that has led us to be able to do really creative work. There are certain groups that are eligible, that have to be eligible in every state: pregnant women, children, parents with dependent children, and certain disabled people who are, and elderly people who receive SSI, children in foster care. And then there's a host of optional eligibility categories that states can implement at their discretion. Another thing that's been really important to studying the relationship between Medicaid and health and poverty is how much it has changed over time. So the program has evolved considerably from its early days when it was first signed into law, and was really at that time kind of associated with cash welfare. So the program was generally for people who were receiving cash welfare. It was generally limited to parents with dependent children, and it was largely limited to low-income single mothers. And over time, the program has expanded dramatically, starting with expansions for children in the 1980s, expansions to pregnant women in the 1990s, and then two pretty significant expansions in 96 and 97. When welfare reform came into effect, it broke that link between requiring Medicaid to be correlated with cash welfare, and states were then able to expand their Medicaid programs to parents, even if they didn't receive cash welfare. And in 1997, the Children's Health Insurance Program came into effect, which expanded Medicaid and, well, it expanded public health insurance access to children with incomes quite a bit higher than the original Medicaid eligibility levels. States did a lot of experimenting throughout the 2000s, expanding access through waivers to some childless adults, to family planning, and to a whole host of other services. And then in 2010, the ACA was passed, and the intention there was to give Medicaid eligibility to everyone with incomes below 138% of the federal poverty level. But the Supreme Court came in 2012 and said, no, thank you, that's coercive. And so states were able to choose whether they were going to expand Medicaid. And I really go through this largely because these are the changes in the program over time that have allowed us to study what it means to have health insurance for people in poverty, and how that affects healthcare and how it can actually affect people's financial security as well. So this is where we stand today on the state of Medicaid expansion decisions. We've got 37 states that have implemented Medicaid expansions under the ACA, 2 that have adopted but not implemented. They're in Oklahoma and Missouri. Our friends in Texas, you all are still, we're waiting on you to implement Medicaid expansion. But it's important to know what this means for Medicaid eligibility across different categories of folks. So as noted, children have pretty high eligibility based on Medicaid and CHIP. Pregnant women also have pretty high and consistent eligibility across states. Where things start to break down is for parents and other adults. So Medicaid expansion states have much higher eligibility for both parents and other adults. And non-expansion states have very low eligibility for parents and no eligibility for childless adults. And as a fun fact, the parental eligibility threshold in Texas is a whopping 17%, which translates to about $3,700 a year for a family of 3. So that's the amount you would have to make. You'd have to make less than that to qualify for Medicaid as a parent in Texas. Okay, so those line up then with who has Medicaid coverage. So low-income children, extremely likely to have Medicaid coverage in 2018. Slightly higher income children are also pretty likely to have Medicaid, and higher income children, excuse the sirens, are much less likely to have Medicaid. And similarly, parents are a little more likely than childless adults, and those numbers decrease drastically as income goes up. So with that all said, where does this leave us? What can all of this public health insurance expansion tell us about the relationship between poverty and poor health, and how has the Medicaid program disrupted that relationship in which poor health causes poverty and poverty causes poor health? So every single one of these bullets could be an entire talk on its own. And so I am going to very quickly kind of run through highlights of the evidence that Medicaid and CHIP improve access to use, access to care and use of care among people in poverty. I'm going to talk about a little bit about how Medicaid and CHIP improve health outcomes. And then really importantly, Medicaid and CHIP go beyond just healthcare, and there's quite a bit of evidence that Medicaid and CHIP have improved financial stability and security for people in poverty. And some of the most exciting work out there right now is evidence that suggests that Medicaid and CHIP in childhood has really important long-term implications for health and economic outcomes in adulthood. So starting with, I think, what's the most obvious is Medicaid and CHIP increases people's access to healthcare and their use of healthcare services. This shouldn't be super surprising. Medicaid and CHIP are health insurance programs. They are intended to increase access to care, and unsurprisingly, they do. They do that for children. They do it for pregnant women. The Oregon health insurance experiment is something I was going to touch on for just a minute, because it really provides some of the most exciting and strongest evidence of the effects of Medicaid on all of the outcomes that we're going to talk about. Because in 2008, Oregon wanted to expand Medicaid. They didn't have enough money, so they ran a lottery. And when they ran that lottery, it was randomized, and some people won and some people lost. And that was an incredible opportunity to study the effects of Medicaid on a whole host of outcomes. And so that experiment, while limited to Oregon, because of its strong study design, has really provided just some of the most exciting evidence about the effects of Medicaid. And they find tons of evidence here on access to outpatient visits, compliance with preventive care, and a whole host of other things. And then, of course, most recently, the ACA Medicaid expansion has been used to study the impacts of Medicaid, and we've found a ton of interesting evidence on access, use, and affordability of care under the ACA. While many people were disappointed when the ACA Medicaid expansion was made optional, it has been a real boon for research. So we can take that as our silver lining. Now, it's a little bit less clear oftentimes whether Medicaid or other health insurance actually improves health outcomes, because so many other things affect health outcomes, and so access to care doesn't always translate. But there's been a ton of evidence coming out of both Oregon and the ACA Medicaid expansion, finding that yes, in fact, Medicaid does improve actual health and not just use of care. Oregon found evidence of self-reported health improvements and increased diagnosis and treatment of chronic conditions. The ACA Medicaid expansion has found similar evidence on self-reported health, improved control of hypertension, improved surgical outcomes. Some of the really interesting evidence on mental health that's come out of both studies, and this is some work that I've worked very closely on, has been on the effects of Medicaid on mental health status. And so that's been really, really interesting because both studies, both experiments found that Medicaid improves mental health status, but a common finding was that these improvements happened really quickly, almost immediately after people gained coverage. And that was generally surprising because it didn't feel like enough time for people to actually get care and take medication and sort of receive the type of care that would improve mental health status. And so there's a really strong suspicion that that is due to actually reduce stress and anxiety surrounding the financial costs of healthcare, that that health insurance improved mental health status so immediately. And then finally, the biggest health outcome of all, of course, is mortality. And it's often been very hard to identify whether or not health insurance actually improves mortality, but using some great new data and a strong research design, some researchers have recently found that the ACA Medicaid expansion did in fact reduce mortality among low-income adults by about 9%. And they estimate that it saved about 19,000 lives and could have saved about 14,000 more if the other states had expanded. Now, this is where things I think get really interesting because we shouldn't be super surprised that Medicaid improves healthcare access, and we certainly hope that it would improve healthcare outcomes. But what it also does is improves financial security and potentially reduces poverty. And there's a couple of mechanisms here that through which Medicaid can help improve financial security. The first is that it just reduces the financial burden of medical spending. And at the extreme end, it reduces the likelihood of bankruptcy and catastrophic spending. But the other thing that it does through those mechanisms is it frees up resources for non-medical spending on things like education or transportation or housing or other things that can really be helpful. And it connects families to other social services, which can also aid in reducing financial problems and can aid in reducing poverty. So Medicaid connects people to SNAP oftentimes, and in that case, that can further reduce financial strain. So there's a bunch of evidence here. I am not going to get into the details of supplemental poverty measures and the ways in which a lot of these studies were done. I'm sure that is an area of great interest to some folks, but largely, the evidence has used sort of the supplemental poverty measure and the way in which Medicaid would reduce out-of-pocket medical spending to calculate how many people would be sort of kept out of poverty through Medicaid. And there was a study just before the ACA that used that approach and estimated that Medicaid kept as many as 3.4 million people out of poverty in 2010. And since then, a similar approach was used to see how much the Medicaid expansion has affected poverty. And they find that the Medicaid expansion pulled almost 700,000 additional Americans out of poverty since 2014. And beyond that, there's been some really great and clever studies looking at credit score data and other types of really interesting administrative data to look at how much Medicaid has reduced other financial stress like personal bankruptcies, bills sent to collections, it's improved credit scores. There's a really great study on evictions that I didn't cite here. So there have been a tremendous amount of evidence that Medicaid goes well beyond health in terms of its ability to improve people's financial circumstances. And then, as I mentioned, some of the most exciting work out there on how Medicaid has helped to sort of disrupt this relationship between health and poverty is through studies of childhood Medicaid and their effects on adult outcomes in adulthood. So health outcomes and economic outcomes in adulthood. And this is really fascinating because we are now at a point where those children who were the beneficiaries of the expansions in the early 80s are now adults. And we can see what exposure to Medicaid did for those children as they grew up. And there's just growing evidence all the time on that it improved health and that it improved education and economic outcomes. So we see evidence of reduced hospitalizations and ED use in adulthood. lower incidence of hypertension and obesity, and in fact, even reduced mortality, which was concentrated among Black children who were exposed to Medicaid in childhood. And the effects on education and economic outcomes are also really fascinating, I think. So we see evidence that if you were exposed to Medicaid in childhood, you're more likely to complete high school, you're more likely to complete college, you have higher earnings in adulthood, and there's evidence of increased intergenerational mobility as well. So the Medicaid program has really had a critical role in disrupting the sort of relationship between poverty and poor health that we talked about earlier. And it's done that both by improving health so that health can lead to better income outcomes, but it's also directly really had an effect on poverty through some of these other mechanisms. So where do we go from here? Lest this come off sounding like an ad for Medicaid, I thought I should mention some of its drawbacks. It's not perfect. There is a lot of strong theoretical evidence that Medicaid should incentivize people to work less because you have to earn below a certain income to qualify for Medicaid. And so in theory, that should make people want to work less to maintain their Medicaid eligibility. I should also say that the evidence largely does not bear that out. There have been several studies that have tried to identify an effect of Medicaid on work status, and it largely has not shown that Medicaid has reduced people's working. I think that's largely because you can't eat healthcare, and so people still want to earn money, but that's just my personal opinion. So the other thing, of course, is state budgets. Medicaid puts a ton of pressure on state budgets, and it puts that pressure on state budgets at times when they are the most fragile, because when people are eligible for Medicaid is during economic downturns, and that's also when tax receipts go down. So it is a very challenging issue for states for sure. And to keep those costs down, Medicaid typically pays providers much less than other payers. And so that can result in limits to access and limits to quality that have been found as well. So it's not the only way forward to kind of try to disrupt this relationship between poverty and poor health. There are both sort of incremental other options like expanding Medicaid more, expanding subsidies in the marketplace, introducing a public option all the way up to single payer. And then the same thing on the economic side. You could give this same talk, I think, about the EITC in thinking about all of the ways in which the EITC directly affects economic outcomes and indirectly affects health outcomes. And there could be almost a mirror image talk about the EITC, and going all the way up to the extreme version of an economic policy of a universal basic income. So I think that's all I have for today. I've left my references in case people are interested. And I thank you very much for your time.
Okay, well, thanks very much. And that was a very compact and very thorough and amazingly informative presentation. So particularly for someone, and people in the audience, but also yours truly is by furthest thing from being a specialist on the effect of Medicaid or health insurance programs on health outcomes. But exactly the question I had was the one that you prefigured right at the end, was what do we know about the other approach in terms of adding income and through the ITC or through experiments and more comprehensive income subsidies? Do we get a similar degree of effect? Making people wealthy make them healthy? It is well known that it does not make them wise, but 2 out of 3 would not be bad.
Yeah, so I think it's a fantastic question, and it's such an interesting area of research. It is not one that I've worked deeply in, but it is one that I have sort of tried to read a little bit about. There is, I think, as I said, interestingly, the first studies of EITC focused on sort of the economic outcomes, and they have now moved on to focusing on the spillover effects to health. I have some colleagues at Urban who recently just found strong effects of EITC expansion on maternal mental health. And there have been, I think, numerous studies that have gone down the health route with the EITC. I think they all find positive effects. I don't know about the order of magnitude. I would venture to guess that because they're a spillover, maybe they're smaller than the sort of direct impact of Medicaid on health, and whereas the spillover on economic outcomes from Medicaid might be smaller than the direct effect on economics of the EITC, but you can't quote me on that because I'm not sure about the magnitudes.
Let me just ask another question, which is a kind of blue sky here, but since we've got obviously very expert person, maybe you have some answers. To what extent do we know, do we have really useful evidence based upon comparison across countries, comparison with Canada, comparison with European systems? Do we have health outcome work that would give us some guidance to what kind of system is most effective?
That's a really great question. So we do know that we spend a lot more and don't get the same outcomes as other countries. So we certainly know that. It's really hard, I think, from the aggregate data that we have from other countries to really know what's driving outcomes. And I think because sort of as you alluded to with the economics, the other social policies in other countries are also so different that focusing only on the healthcare system and looking at how healthcare systems differ wouldn't probably be enough, because I think the other social supports that are provided in other countries are so strong that you would have to look at everything as a package almost to really understand what was going on.
I'm anxious to hear from the audience. I'm sure people do have questions, but I'll toss out a couple of more. Can you say a few words about how Medicaid reacted, how elastic it was in the face of, let's say, the financial collapse in 2007, 2008? Just give us some guidance as to what kind of responsiveness we see in this program and to periods of financial distress. How quickly do people get service? How much does it matter to them? And I was going to get to that, and then I'm going to throw out a question about the pandemic.
Yeah. So I think the answer is because Medicaid is an entitlement, states have to accept people, right, when they apply for Medicaid if they become eligible during an economic crisis. So they're pretty responsive. The participation varies a lot across states in terms of how quickly people actually get on board. And I think it won't be surprising to anyone that the states that are generally more supportive of the program, they have more outreach and enrollment activities. They have navigators that can help get people enrolled. They have sort of more support for the process. They tend to do better. They tend to enroll people faster. They tend to retain people more. To the states that set up more barriers, more re-enrollment deadlines, more paperwork, tend to not do as well.
Do we have studies of that? Is there documentation that we can
There's definitely documentation on sort of patterns of churning and on and off the program, and patterns of retention and some of the policies that lead to that. So there's sort of different eligibility policies. Some states have, largely for children, have continuous eligibility, whereas for adults they don't. And so you can really see how some of those policies really actually move the needle on whether people get enrolled and whether they stay enrolled.
And what do we know so far about the role of Medicaid in response to COVID-19? Is there enough evidence of that yet?
That's much harder, I think, to say because the data lags are so strong. But we do actually, some of my colleagues at Urban just are doing a coronavirus tracking survey. And so they just put out a brief, I think this week, that looks at changes in coverage between March and September. And what they see is a big drop in ESI, which is unsurprising, so in employer-sponsored insurance coverage, and that it was largely made up by increases in Medicaid and increases in non-group or marketplace coverage, so that there was not a substantial increase in uninsurance over that period. And so it does look like there was real responsiveness under the pandemic, but it's one study. So I want to be cautious, but it looks pretty positive as of right now. They were also required to maintain people. So in order to get extra federal matching funds under the, I don't remember if it was the CARES Act or the other one, but Medicaid programs were required to not disenroll anyone who was already enrolled, which normally is something that happens fairly often.
So in some sense, the system held. That's really fascinating. Thank you. And I've exhausted my imagination.
Yeah, so I have a few questions.
I will turn it over to Patricia, who has much more than I do.
No, but you did touch on one topic that's always been of major interest to me, and that is the trade-offs between providing services as opposed to providing income. So in the case of Medicare or Medicaid, you're essentially saying, we believe that healthcare is important, so we're going to subsidize it. And the alternative approach is to say, we believe people should be able to make their own decisions about what they want to spend their money on, and so we're just going to give them money. One of the points you made, which I think is really important, is that having access to insurance, and particularly to Medicaid, has the great advantage of limiting the risk that people are associated, are exposed to. And so, that's kind of a major argument for providing services, is that people are not always in a position to limit risk themselves. And so that, that's a stop loss. But could you talk a little bit about what you see as the advantages of, each of these approaches to helping people escape poverty?
Yeah, I mean, it's a great question. And I mean, I guess I'm biased partly by the fact that I've spent my career studying the healthcare side of things. So I certainly support the idea of providing access to health insurance as a mechanism to both improve health and to improve people's financial security. The trade-offs are harder, and I'm kind of now fascinated to go back and kind of compare some of the magnitudes of these studies. I actually think that would be a really cool exercise to go through and compare the magnitudes of some of the effects of the EITC versus the effects of Medicaid, and try to really actually disentangle what the sort of cost benefit is there a little bit, and understand the trade-offs a little bit better. I mean, giving people flexibility of what to do with their money is certainly a good thing. It's often not politically popular to give people money. And so I think there has often been a stronger argument to give people services that someone else decides are valuable, as versus allowing people to make those choices. But we've also seen that many states have also not done that, right? So maybe there's an argument to try to convince, say, like some of the more right-leaning states, that if they believe in sort of freedom of people's choices, then maybe just give them money and they can decide what they want to do with it.
Well, there would be some political issues there as well, I suspect. But
I believe that. But
I've also heard people refer to Medicaid as a stop-loss program for hospitals. Can you talk about the extent to which the impacts of Medicaid on on the institutional side of our healthcare system, and
yes.
what that means for low-income folks?
Yes, it's a great question, because there's a whole other literature looking at that very question on how Medicaid has, particularly under the ACA Medicaid expansion, how it's reduced uncompensated care costs at hospitals, how it's reduced hospital closures in rural areas. So it is really sort of propping up hospitals in many ways. And that's despite the fact that you often hear complaints about how bad of a payer Medicaid is, but it's certainly better than being uninsured. So it has definitely helped hospitals' financial situation quite a bit, which is why you generally get support from the hospital industry for coverage expansions, because they definitely get more revenue coming in with that. And so, and I think some of the evidence on hospital closures is also really interesting. So there's been a real trend in the hospital closures in rural areas, and that was stemmed in Medicaid expansion states a little bit.
Mm-hmm.
Well, let me toss out a question though. I don't know if you noticed, but we over the last week or so, we held an election in the United States, and there will apparently be a new administration coming in a few months.
We never know. But
I wonder if you have a word of advice, or if you have a priority that you would put in front of the transition team if they called you in. Maybe they will.
Somehow I doubt that, but you know, I mean, I think one of the things that I know is sort of a part of Biden's healthcare plan, and I think is maybe the most important piece of this puzzle, is figuring out how to get some level of eligibility to the folks that have been left in that coverage gap due to the Supreme Court decision. So the folks who have incomes below poverty in states that chose to expand Medicaid have very little access to any kind of supported health insurance coverage. Childless adults have none. As you saw, parents had really low rates of eligibility in non-expansion states. And so I think that's really the area where you'd like to see something happen. And the way to do it federally, I think, would be by just extending the marketplace subsidies down below 100% of the poverty level, which wasn't done because Medicaid expansion was supposed to go up to poverty. But once the Supreme Court ruled, it left that gap. And I think that is a component of the Biden plan that I think I would certainly support.
A major reason for states not, other than sort of basic political considerations, not participating in the expansion has been the fact that there's a match, that expanding their own programs requires states to spend at least some of their own money, although they also get substantial federal subsidies. Yeah. Do you see changes in the match rate or in match policies more generally as a fruitful way to think about how to extend Medicaid?
Yeah, that's a good question. So one of the things that I do think is a fair criticism or concern for states that have chosen not to expand is that while the match for newly eligible adults is extremely high, so it's upwards of 95% or 90% now, I guess.
The federal part of the match.
The federal, yes. Sorry, yes. The federal piece is up to like 90%, I believe, at this point. Now, that's not nothing that states have to contribute, of course, but it's very high. But it's much lower for parents. And so I know that a concern of some states is that there is this spillover effect, would work or welcome that, however you like to call it, in terms of when a state expands, people who were already eligible also often end up getting coverage. So people who were eligible as parents or people who were eligible as children. And that match, the states have to contribute more. And so I think states are also concerned about that issue. So there could certainly be an argument for raising the other matches for parents or for children.
I think states have also, or at least I've heard governors express the fear that at some point the higher match is going to go away and they're going to be stuck with all of these people who are now eligible under their programs and they're financially responsible for all of them. Do you have any thoughts on how likely that is and what you could do to reassure folks in those states?
I mean, that's so hard to say. I think, politically, it really depends on who's in the driver's seat. I don't see the federal match decreasing beyond where it is now, but it's hard to know. It really depends on what happens in the economy. It depends on what happens with other policies. I mean, right now, I think the proposed option for dealing with the coverage gap is to give basically 100% funding to those folks. So that's even more than they're giving to Medicaid expansion, right? So the feds are paying 90% of Medicaid expansion. They'd give 100% essentially to get those folks enrolled in the marketplace. So maybe the waiting game could work out for states if they waited to not expand Medicaid, and now they could get their folks covered without paying anything. So maybe it was a good gamble.
Although presumably the states that went ahead and expanded would also benefit from whatever changes were made. But
and so that's actually a real question that I haven't thought about, whether any states will pull back their expansions if people below 100% are eligible for marketplace. So will they pull back and say, okay, well, if you're going to fully subsidize our poor population, then we don't need this Medicaid expansion anymore, where we're kicking in 10%.
Mm-hmm. In a way, you can think of 100% federally funded Medicaid expansion as a form of universal coverage.
Absolutely.
And it's essentially just a means-tested form of universal coverage. Is that one way to transition towards a broader healthcare system, do you think, or do you see major obstacles there?
I mean, I think it certainly is, and I think some folks have proposed something like that, where you would sort of phase people in and enroll people in Medicaid when they're born and have this roll out very slowly so that we eventually have sort of a fully subsidized system. So yeah, I think it's absolutely Medicaid for all, I think, is actually a much more realistic version of what a single payer system looks like than Medicare for all. I mean, Medicare is such a complicated program with so many different parts and all of its nuance. I often think that Medicaid for all is much more like what people imagine a single payer system would be. The biggest drawback, I think the biggest concern, and where you're going to see the biggest pushback is on that provider payment side. So right. Medicaid pays providers poorly. And as I mentioned, when it's a trade-off between Medicaid and the uninsured, people are happy to take a Medicaid rate. But if you're saying we're going to move people out of private coverage into Medicaid and you're going to get much lower reimbursements for those people, then you start to get the pushback from the hospital industry and from physicians.
How much would they, so order of magnitude, would a shift like that actually reduce total spending on healthcare in the United States?
That's a great question that I don't know off the top of my head, but so I think Medicaid on average pays like 70% of Medicare, but that doesn't get you to like what the total spending change would be. Right. Those estimates are out there, but I don't know off the top of my head what that is.
And typically there'd be some major behavioral effects as well. If people could get free or heavily subsidized coverage,
of course,
then you would probably see more people getting coverage.
Yep.
One aspect you haven't talked about is obviously not connected to CHIP per se, is the role that Medicaid plays in providing care to older people, to the elderly. I want to just say a few words about that, just to.
Yeah, absolutely. So there's two main ways, I think. So Medicaid provides support for people low-income people who are enrolled in Medicare in terms of paying their premiums, paying their deductibles, and paying their copays. So you can qualify as a dual eligible, and Medicaid can provide support for those low-income elderly folks. The other place where Medicaid plays a huge role is in long-term care. And so because Medicare doesn't cover long-term care, Medicaid effectively covers long-term care if you spend down all of your assets in order to qualify for it, essentially. And so Medicaid is a very important payer for the nursing home industry. And
Do you know about what proportion of total nursing home expenditures are covered by Medicaid? I mean, it's very substantial, right?
substantial. I don't know what the number is. And
But
it would
on
be,
the order of-
yeah, it's interesting because it also is not a great payer. And so how the dollars line up to the people would also be interesting, because it might be more people than
Yeah.
dollars, because people who are paying privately are paying more.
Yeah.
But yeah.
And here you run into the problem that, as is widely known or widely believed, that programs for the poor are always poor programs. That you know, that if you limit something to poor people, then there isn't really a lot of political desire to make it a better program.
Yeah.
So it seems to me the downside of approaching universal coverage from a Medicaid route would be that, as you say, it might perpetuate two different standards of care, two different systems with, you know, much less effective care for folks in the lower half of the income distribution than those above. Of
Yeah,
course, we have that already, but
I think the one thing that has actually come out of the ACA Medicaid expansion in the last 6 years or so is a real support for Medicaid, much more strongly than had ever been true before. And I think that is because it has expanded beyond the extremely poor. And it is covering so many more people who are working, and families and single people. And it really has broadened the support for the program in a way that I think has really never been true before. Before it was such a niche program. And I think now there's just, that's been one of the interesting lessons, I think, of the ACA, that it really has shown, and because the evidence has actually been pretty strong for its quality as well. So I think both of those things over the past 5 or 6 years have really, I think, done good things for Medicaid's reputation, and could lend itself to using it as a mechanism to move forward.
I've been appealing for questions, and the Sergio Plaza has offered one that it's on a topic that you touched on briefly, but perhaps you could say a few more words. Ask, what are the long-term index on mental health for adults that had Medicaid or CHIP in their childhoods? Do we know anything about that?
Ooh, mental health. Gosh, I don't think I have a study in mind. There's been a lot, so mental health can be hard to measure in some of the bigger data sources that have been used to do some of this work. But I want to say that at least one of Laura Wary and Sarah Miller's studies did look at mental health, and I wonder if they didn't find a strong effect, because it certainly wasn't in the kind of overview that I had included as one of the metrics, and I don't know if that's because they didn't look at it or they didn't find an effect.
Mhm.
And so that's something that I would have to look back at, but yeah.
One of the, I mean, continuing more or less on the topic of what are the long-term effects of Medicaid, one of the things that people argue is that we aren't really properly counting the benefits of programs like Medicaid, because to the extent that they improve people's health, particularly in childhood, they prevent a lot of costs later in life, and also contribute to higher wages and higher earnings capacity and stuff like that. Do you know of any estimates of what those kinds of investment effects might be?
There is one of the studies that I had cited, and I'm not going to remember the exact number, but they looked at basically how much of Medicaid's costs of covering kids are kind of recouped by the higher earnings that they make in adulthood. And I want to say it was 58% is sticking in my head, but I'm not sure if that's accurate. So I would have to look back at what that is, but there have been some attempts to kind of navigate that. It's largely been on childhood Medicaid because that's been the area that it's been sort of most straightforward to track because of those expansions in the early 80s provided really useful variation for looking at exposure in childhood and outcomes in adulthood. There have also been some studies that have used the introduction of the program to try to look at the longer term effects. And I don't know that the results have been as strong because I think the variation is harder to like work with because it doesn't vary by state.
And it's unfortunately harder to argue that saving us old people is, really cost effective. But yeah, I suppose you could argue that much like with Social Security, there are spillover benefits for the children who don't go bankrupt trying to support their parents.
Yeah.
So that's always been one of the more popular aspects of Social Security. It means that you can get off the hook for taking your elderly mother into your home.
Well, there's certainly strong evidence of spillover benefits of covering parents for kids. And so I think that you could extend that to sort of the spillover benefits of covering the elderly for their children and then for young children. So there's a lot of 2-generation work right now, but there could be a 3-generation argument for sure.
So, well, thank you very much.
To make a slightly facetious suggestion and to tell a small story, I was in Havana about 15 years ago, last year's of the second Bush presidency. And I gave a talk to the Ministry of of Trade, I believe it was, External Trade. And I suggested that the one thing that they should press for is the relationship improved with the United States was a treaty on Medicare and Medicaid that would simply allow them to take as many elderly as they could handle and get a slightly discounted reimbursement rate. And, nice weather, excellent medical system, low crime. I mean, and only 90 miles from Miami or from Florida. And the answer came back was very interesting. It said, "We're already talking to American nurses." So if you do have input to the transition team and want to pass along that suggestion, my advice would be to do it anonymously. Do it anonymously. Or you can credit me and say you just heard it from somebody.
I don't think I can use the Urban Institute to endorse that.
Exactly.
And I would like to point out this is also not official LBJ School policy.
Nothing I say should be attributed to the LBJ School, the university, or the state of Texas.
Right, exactly.
All
disclaimers apply.
Okay. Listen, this has been absolutely fascinating. I must say, in just a few minutes here, I've learned more about this program and about the range of things that are available as information about it than I think I've picked up in my previous 35 years as an academic. So I would, and I'm sure that's probably not true for others in the audience who know a good deal more about it than I do. But I just want to say thank you for an extremely high quality presentation and very, very quick responses to a whole barrage of questions, some of them predictable and others perhaps a little bit off the wall. In any event, I'll let Patricia close this out.
All right. Well, again, thank you, Stacy. That was really, really helpful. And I think it does help to illuminate the extent to which health and poverty are, very tied concepts. And as you say, it goes both ways. If you're poor, you're less likely to be healthy. And if you're not healthy, you're more likely to be poor. So I think it helps to illustrate for us why it's really important to think about health issues in thinking about a comprehensive approach to poverty. So we really appreciate your coming on and talking to us, and we'll look forward to talking to you again.
Sounds great. Thanks. This was fun.
You might say a word about what we're doing next week. I think we
right. Jamie, do you want to cover that?
No, I think you should, because at the moment I've forgotten who have we got next week. It's
Well,
Derek.
sadly, so have I, Jamie.
It's Derek, isn't it?
Yes, that's right.
Yes,
Derek
so
Hamilton.
next week we have Derek Hamilton, and who will be extremely interesting. Has been tied into the political developments of this past year in a very major way, and has a great deal to say on many aspects of the poverty question, but particularly the racial divide.
That's right. All right. Well, thank you again.